Hello, my name is Kathy Jo Stent, and I'd like to welcome you to this WebEx presentation. It's on aligning outpatient services to the ASAM criteria. This presentation has both audio and visual content, and in order to access the slides, you must join this presentation via the specific Skype link that corresponds to this particular webinar on the presentation schedule. You can access the schedule by visiting www.ddap.pa.gov. Then you select the For Professionals tab at the top of our page, and then navigate to the ASAM transition page. This presentation will provide a high-level overview of the documents recently released on 1.0 Outpatient Services. There are two documents or parts: the Outpatient Services by Service Characteristics and a self-assessment checklist. Information from a third document, the Pennsylvania Expectation Addendum, will also be reviewed today. I would encourage you to have the reference documents available during this presentation, since we will be doing a high-level review of them. The documents were previously sent out via DDAP's listserv on July 20th, but they are also available on the DDAP website. If you need to access them from the website now, you can locate them by going to the same website, www.ddap.pa.gov, then by clicking on the For Professionals tab at the top, and then navigating to the ASAM transition page. Please note that this presentation only includes information specific to the Level 1.0 outpatient services. Additionally, DDAP and DHS are still working on finalizing details about co-occurring. Therefore, specific details about the delivery of co-occurring capable and co-occurring enhanced services will be addressed at a later time. The service description document is an abridged resource of the information presented in the ASAM Criteria 2013 text, and the self-assessment checklist is a document that will assist providers in self-gauging where they are at in the alignment process. These documents are a resource for service alignment. However, they should in no way be a substitute for completion of approved training on the ASAM criteria or for having a thorough awareness and use of the ASAM Criteria 2013 text. There is a lot to cover in this presentation. Therefore, questions regarding today's presentation or the 1.0 documents should be submitted through email to ra-daasam@pa.gov. Questions and answers will be addressed through subsequent webinar sessions to be held on August 28th and August 31st, and a written FAQ that will be posted on DDAP's website following the Q&A webinars. This email address will be provided again later in the presentation. As a side note, while the various documents for each of the levels of care are being disseminated separately, all of them will eventually be combined, along with the guidance document and any changes that have been made along the way, and will be in a combined single final document for ease of reference. Currently, all ASAM resources relative to Pennsylvania are located on the DDAP website. As a review of what we have done so far regarding the ASAM transition and alignment, efforts have been underway over the last several years to transition and align with the ASAM Criteria 2013 in support of Pennsylvania's implementation of its 1115 waiver, for moving to an evidence-based practice assessment and service delivery criteria, and for overall system-wide improvements. Many trainings have occurred during this time frame, with over 8,700 individuals completing the 2-day in-person ASAM criteria skill building training, with additional individuals taking the Change Company's online ASAM trainings approved in January. Guidance documents have been published and released on various occasions. FAQs have been posted, and residential providers have participated in a preliminary level of care designation survey. While agencies have been trained and have been required to use the criteria for level of care assessment, as a whole, we have not directed the official alignment of service delivery to coincide with the criteria. We are now ready to move our system forward with the alignment of service delivery with the ASAM criteria, which takes us to next steps. DDAP has been working collaboratively with the Department of Human Services in effort to support service providers and payers in aligning with the delivery of services as described in the ASAM criteria. The alignment focuses on setting, supports, staff, therapies, assessment and treatment planning, and documentation. Providers should begin working towards alignment in the various areas identified in each document and this presentation immediately, but incrementally, as needed to appropriately address each item. DDAP will be posting a timeline on its website to assist with proposed completion times, most of which will occur July 1st, 2021. Please reference the timeline resource for anticipated progress of alignment with the criteria moving forward. Foundational to the alignment process is understanding that the licensing requirements for each level of care are minimum standards for operation. A drug and alcohol license is required for operating. Alignment with the ASAM criteria is an expectation of quality required as a contracted provider receiving state or federal funds through the SCA or Medicaid that goes beyond the minimum licensing requirement. A provider will not be able to hold a contract to receive public funds without aligning to the ASAM criteria. As stated very early on in the move to using the ASAM criteria, doing such was both an event and a process. There was a date by which all assessments, continued stays, and discharges completed were to be done using the ASAM criteria. This has been accomplished, and assessors and clinicians have become familiar with the criteria over the past year or so. Now we are ready to proceed with aligning our services to the descriptions as outlined by the criteria. While we will have target dates for completion of certain aspects of this alignment, not everything should be done at once. Providers should address the alignment over the next several months to ease into the expectations by July 1st, 2021, rather than waiting and having to address necessary changes all at once. Many of the issues of alignment are already occurring or are mostly occurring and can happen more readily, while others may require more effort. In all cases, DDAP and DHS will make every effort to support our provider network in aligning with the criteria, as we believe in the importance of working together to improve our system and to deliver an even higher quality of service than we have been accustomed to in the past. Hopefully, if you did not already have the documents in hand, you have them now. This slide shows you a miniature version of what we're referencing. Let me point out that documents for every level of care have a similar layout that corresponds with how the information appears in the ASAM text, flowing through setting, support systems, staff, therapies, assessment and treatment plan review, and documentation. While each level of care has the same categories of services and even many overlapping requirements, of course, distinguishing criteria exist for each level of care. As you work to bring your program into alignment, you will want to use the documents applicable to the level of care delivered in your program in tandem with the ASAM criteria text to fill in any gaps. The self-assessment document and the Pennsylvania Expectation Addendum will be especially helpful in aligning your programs to the criteria. I will highlight some of the requirements as we go through this presentation, but not all. So be sure to familiarize yourself with these resources DDAP has provided. So let's get started. Outpatient services are provided in freestanding facilities, which can be found in a variety of different settings. All outpatient drug and alcohol outpatient providers must be fully licensed in order to operate and conduct business. More specifics regarding licensing procedures can be found in the Pennsylvania licensing regulations. This level of care has the ability to support a number of different situations for treatment. For example, outpatient is appropriate for individuals who recognize their substance use or addictive disorder and are committed to recovery. This level of care can be used as a transfer from a more intensive level of care. Level 1 can also be used for individuals in the early stages of change who may not have much internal motivation to increase their readiness for change, to encourage engagement in the therapeutic process. This is probably one of the more notable shifts with aligning to the criteria for outpatient treatment. Historically, when an individual was deemed quote unquote resistant to treatment or didn't recognize his or her use as problematic, we were more apt to refer them to a higher level of care, including residential services, rather than using outpatient as an opportunity for engagement and motivation to change. But it does make sense to engage individuals at the outpatient level and utilize motivational interventions to assist someone in recognition of his or her substance use as an issue and to determine actions that can be taken to address it. Level 1 may also be used as maintenance for individuals who have achieved stability in recovery. Lastly, outpatient may be used for ongoing monitoring and disease management indefinitely, as is done with chronic diseases such as diabetes. This would likely occur through check-ins done at a less frequent occurrence than with someone just beginning treatment. There is no established length of service, as treatment should be based on the client's progress on their treatment plan. As reiterated through the ASAM Criteria 2013 text, individualized treatment with variable lengths of stay are foundational and key to moving away from program-driven care. While we generally think of the 1.0 level of care as being standard outpatient, it is important to remember that narcotic treatment programs or methadone maintenance programs are also licensed as outpatient providers. Therefore, Pennsylvania outpatient regulations will apply to both, as will the ASAM criteria, although each of these services will also have unique requirements or applications as well. Supports identified for Level 1 are those services that should be readily available through adjunct agencies to collaboratively meet the needs of the individual. As indicated on the slide, example of these services include physician access, affiliation with other levels of care, pharmacotherapy, and case management services. Some of the supports, such as nursing staff or medical staff, will likely be available at an outpatient methadone maintenance program or NTP, or maybe even some co-occurring enhanced facilities that do on-site medication management. But for the most part, at general outpatient providers, medical support services, psychiatric services, lab and toxicology services will be done through referral and affiliation, in which case written documentation in the form of MOUs or memorandums of understanding or letters of agreement should exist to formalize the relationship with these collaborative agencies where appropriate. With Level 1.0, it is important that clients have access to emergency and crisis services by telephone 24 hours a day, 7 days a week for the purpose of stabilization. Some facilities may have a rotating on-call service manned by facility staff. Others may opt to utilize crisis management to field 24-hour calls, while others may have a hotline. Both traditional outpatient and narcotic treatment providers are licensed as outpatient providers. However, the reference to pharmacotherapy applies to all levels of care. When referencing traditional outpatient providers regarding access to pharmacotherapy, it is important that individualized care is occurring for each client. Individuals cannot be denied services based upon their use of FDA-approved medications to treat substance use disorders. Pharmacotherapies, which are considered best and evidence-based practice, should be available while a person is engaged in traditional outpatient services, either directly or by referral or coordinated services. Access to all forms of FDA-approved MATs is essential to the provision of individualized care. If MAT is restricted to a particular medication, but that medication is not appropriate for a given individual, he or she is prohibited from accessing the medication that is best suited to meet his or her needs, which is not best or evidence-based practice or individualized care. Therefore, should a provider not accept individuals on all forms of MAT, individualized care cannot be delivered, and that provider would not be eligible to receive substance abuse block grant or SOAR funding for any service. Should a client be denied services due to being on MAT, it is then the responsibility of the SCA to ensure that the individual is able to receive the needed services from another provider within the SCA's provider network. The requirement for pharmacotherapy is consistent across all levels of care. All clients receiving Level 1.0 are not mandated, but are entitled to receive case management services. In fact, as best practice, case management should be offered as a standard delivery of care. Case management is defined as a collaborative process that assesses, plans, implements, coordinates, monitors, and evaluates the options and services required to meet the client's health and human services needs. DDAP is working with the SCAs to strengthen case management services as a distinct and separate service from the clinical process, so that individuals have the support they need while allowing clinicians to focus on the therapeutic process. The clinician and case manager should work collaboratively along with others to form the interdisciplinary treatment team. With regard to staffing, that which is outlined in the Pennsylvania regulation remains applicable as a minimum standard when aligning to the ASAM criteria. Staff must meet the minimum education and training requirements, or METs for hire, and the staff-client ratios will remain consistent with PA regulation and cannot exceed 35:1. Moving beyond the minimum requirements of the PA regulations, staff also need to either have professional licensure or those certifications issued by the Pennsylvania Certification Board, or PCB, applicable to the assigned duties of the staff, or be working toward these quality standards after hire. This requirement is more fully outlined in the addendum document, as we will discuss in more detail later in this presentation. As has always been the expectation, ongoing adequate and appropriate training directly related to the population and services delivered remains imperative. For example, clinicians providing services to pregnant women or women with children should have training on the unique clinical needs of women. Those serving adolescents should have specific training and education regarding adolescence. Those serving veterans should know about the needs unique to this population, etc. As stated, DDAP and DHS are currently working on the co-occurring requirements, and it is likely that eventually all clinicians will need to be able to recognize mental health conditions and be capable of assessing individuals' current mental status. However, until all of the clinicians in our system are trained and prepared for this, clinical supervisors will be expected to have a level of competency in detecting and assessing mental health issues and be able to consult and direct their staff in best practice, referral needs, etc. The same expectation would apply regarding the therapies delivered. Staff should be appropriately trained to provide the types of therapy utilized in the therapeutic interventions delivered. Any areas of specialty should be noted on the individualized training plan of each staff, and a record of completed population or service-specific trainings should be maintained. Since evidence-based programs and interventions are foundational to the delivery of quality care, training records should include those EBPs or therapies that are embraced by and routinely provided at the facility by all relevant staff. All clinical staff should have a foundational knowledge of motivational interviewing and the stages of change, since assessing readiness or stage of change is foundational to applying the ASAM criteria. Moving forward, there will be an expectation that clinical staff be able to demonstrate proficiency with motivational enhancement and engagement strategies appropriate to an individual stage of readiness to change. A guiding principle of the ASAM criteria is moving away from program-driven to both clinically driven and outcome-driven treatment. Treatment should be individualized based upon the needs identified in the multidimensional assessment. Previously, outpatient services were defined as at most 5 hours per week and were usually a combination of individual and group therapy sessions. The ASAM criteria defines outpatient as fewer than 9 hours per week for adults. This does not mean that every individual at a facility should receive 8.5 hours of counseling. Rather, an individual should receive services at the quantity and frequency that best meets his or her needs as determined by the individualized treatment plan. Delivery of services should be what is therapeutically and individually needed, be it individual and/or group sessions, singularly or in combination. However, these should not be delivered as a programmatic structure suited entirely to the business model of the program. The provider should utilize the ASAM criteria as a tool to assist with the decision-making and appropriateness for placement into outpatient services. The ASAM criteria allows for the flexibility to tailor the treatment needs of the individual and the ability to meet with the client as frequently as needed each week, as long as service hours provided are fewer than 9 hours per week. As stated, the delivery of evidence-based programs and interventions is foundational to the provision of quality care. While educational efforts will be a part of care, clinical interventions should be therapeutic in nature and not primarily curriculum-based or psychoeducational. For example, but not limited to, the delivery of therapies such as cognitive behavioral therapy, rational emotive therapy, EMDT, etc., should be delivered within the therapeutic setting. As stated, motivational interviewing and stages of change is foundational to applying the ASAM criteria. Therefore, training on this topic will be a required element for aligning and using the ASAM criteria. Therefore, moving forward, DDAP will be adding this training requirement for all clinical staff as outlined in the addendum document, and we will discuss this in greater detail later in the presentation. While the majority of outpatient providers will not have physicians and nurses on staff, there is still a need to treat an individual holistically and, whenever necessary, engage the individual's healthcare provider as a member of the treatment team. With appropriately signed consent, referrals to and contact with primary care physicians should occur, and compliance with directives from the healthcare provider, including medication monitoring, should be included in the treatment plan. Case management can play an integral role in coordination of care. While in most cases therapy will be a separate and distinct service from case management, the fact that case management and adjunct services are needed should be noted on the treatment plan, but be delivered by the case manager as a member of the multidisciplinary treatment team. The clinician should monitor progress and involvement. Because substance use disorder impacts the family as a unit, services and counseling with family members is required whenever possible. This is beyond educational sessions. If individuals are hesitant to involve family members into the sessions, the therapist should begin to explore the reasons why, as this may be a therapeutic exercise for the individual in building the confidence to begin to open up to persons whom they consider family, building bridges, and mending severed relationships in the process. As previously stated, an individual cannot be denied access to pharmacotherapy, and whenever possible, coordinated efforts should occur to allow for continuity of care for an individual who is on an FDA-approved pharmacotherapy while engaged in outpatient services. The initial 6-dimensional level of care assessment should be reviewed with the individual and utilized to formalize a complete biopsychosocial, which is then used to prioritize the needs and develop a treatment plan with the individual. Working with the client in identifying strengths, needs, and preferences, the treatment plan should be prioritized by risk. Assessment will need to reoccur during the therapy process so as to accurately reflect progress or current issues that develop over the course of care. While specific co-occurring details will be presented at another time, it is important to note that assessment for any mental health conditions should be determined both initially and ongoing to determine the need for adjunct or specialized co-occurring services. The level of care assessment must be done by an independent source or show evidence of neutrality. Additional details are included about this in the PA Expectation Addendum, which we will discuss later in the presentation. The assessment is reviewed and confirmed with the patient and used to complete the biopsychosocial and the treatment plan. Patients should have a copy of their current treatment plan, and it should be actively used as a resource or roadmap during each individual and group session and to assess progress. Individualized progress notes should reflect the treatment plan, including the patient's response to the therapeutic interventions or treatment modalities used and any amendments made to the plan. Progress should be documented in notes that describe each contact with the individual and how the treatment plan was implemented and the individual's response to the intervention. Progress notes should be completed as soon as possible following the session to avoid lost content. In fact, it is often helpful to summarize the treatment session in writing while still with the client as a mechanism of review and to present the next steps in the plan that are to be addressed during the next session. Progress notes should reflect the treatment plan, progress, adherence, and adjustments or updates made to it. So that takes us through a high-level review of the service characteristics document. Let's move on to the self-assessment checklist. The provider self-assessment checklist includes elements for alignment with the criteria. In addition to the self-assessment, as we progress with service alignment at the state level, there will be a monitoring process in place to affirm the self-assessment completed by providers and that alignment with the criteria has occurred. So, looking at the blue square on page 1 of the self-assessment checklist covering the setting characteristic, a provider would read through each numbered item in the block and place a check mark in the corresponding red circle to indicate that this element already exists at the facility. Those items or red circles that remain unchecked will need to be addressed in order for the program to be fully aligned with the ASAM criteria. Items 1 through 3 in the checklist, a setting that meets state licensure, written policy for program admission, transition, and discharge, and admission criteria for the outpatient level of care likely will already be in place or should already be in place with some minimum adjustments to policy. A key item, in addition to policies that may need to be written for this section, is item number 4, consistent evidence of a variable length of stay based upon patient need. There are 15 characteristics to self-assess under the heading of support systems. Although the checkbox on the slide appears in 2 segments, this is so we could fit it on the screen. In the document, this and other assessment checklists appear as a single box. Many of the 15 assessment points under support systems have to do with policy and procedures for collaborative care or referral for services. As stated earlier, some of these supports will be provided directly by program staff and some by affiliation and referral. Policies and procedures should exist when referrals for concurrent services need to occur, and how these collaborative services will be delivered. And MOUs, or Memorandums of Understandings, and Letters of Agreement should exist where necessary. Additionally, a provider's plan for addressing emergencies with clients must also be addressed in policy and procedure. The items emphasized in the staffing self-assessment checklist include areas such as policies and procedures that outline staff responsibilities, required credentials, etc. It also includes the need for job descriptions. As stated earlier, we will discuss the new requirement about credentials a little later in the presentation. As indicated, therapy hours in the outpatient 1.0 setting are up to fewer than 9 hours for adults, as clinically warranted for each individual. Variable lengths of stay should be evidenced. That is to say, individuals should not receive set hours of care as determined by the program, but that which is needed as determined by the treatment plan. Treatment services may include individual and/or group counseling, motivational enhancement, family therapy, educational groups, psychotherapy, addiction pharmacotherapy, and other therapies. You will notice as part of this assessment checklist, policies for staff trainings and verification of trainings applicable to services delivered. Much of what is addressed in the 15 elements of the assessment and treatment plan review is likely already occurring in your facility. So I'll highlight those most likely to be areas that will need some adaptation to align with the ASAM criteria. There are several items in the list that require having policy and procedure to formalize that which your agency does in everyday practice that aligns with the ASAM criteria. Item number 3, having an independent level of care assessment, which we will discuss in more detail in just a bit. Number 7, indicates that a physical exam is conducted as determined by an individual's medical condition. While physical exams are not required for everyone at admission to outpatient, if someone is indicating physical complaints or obviously has medical issues that are or are not being properly attended to, an appointment and follow-through with the primary care physician or a referral to a healthcare facility if the client does not have a doctor is warranted as part of the treatment plan in delivery of holistic care and to address Dimension 2 biomedical issues. Engaging in an ongoing assessment process. Probably the most asked question that DDAP gets related to ASAM is, quote, how often do I need to do an ASAM, end quote, which translates to, how often should I, as a clinician, reassess my client? The ASAM text on page 110 indicates that regular assessment is necessary in order to determine if an individual remains appropriate for any level of care. Again, with the documentation checklist, providers will go through this list and mark off the items that already exist in their program or determine those areas that are missing in order to come into alignment with the ASAM criteria. There's really nothing out of the ordinary or extreme that needs added explanation in this checklist. I will remind you that while Pennsylvania regulation provides mandated timeframes for when treatment plan reviews must occur, if an individual circumstance warrants a review and change prior to the scheduled formal update, it should occur as necessary to be relevant in meeting the client's needs in the here and now. In reviewing all of the sections of the self-assessment checklist, you see that in many instances, alignment requires the creation of policy and procedure to formalize processes that are likely already mostly in place. As stated at the onset of this presentation, DDAP is encouraging that providers begin the alignment process immediately so that when the date for full alignment occurs, which for a majority of items will be July 1st, 2021, or in about 1 year from now, you will be well positioned to meet the contractual expectations. DDAP will be posting a timeline for alignment to our webpage in the near future. I mentioned that both general outpatient services and narcotic treatment programs fall under the outpatient setting. But our primary focus in this presentation has been on the general outpatient setting. So I'd like to take just a few minutes to talk about opioid treatment services, or OTS, as they are presented in the ASAM criteria. First of all, you'll find that opioid treatment services are discussed specifically on pages 290 through 298 in the ASAM criteria 2013 text. As outlined on the slide, the setting for these services are most usually opioid treatment programs, also historically referred to as narcotic treatment programs, NTPs, or methadone maintenance programs, or they may also be office-based opioid treatment providers, or OBOTs, which are community physicians who are waivered to prescribe buprenorphine. Either of these settings, an OTP or OBOT, falls under strict federal and state guidelines for operation. Waivered physicians operate under their own medical licenses, while OTPs are licensed by DDAP under the 715 regulations, and therefore DDAP only has oversight of those programs which it licenses. The biggest differences for OTPs or NTPs and aligning with the ASAM criteria has to do with meeting the clinical therapeutic needs of the individual. And this is evidenced in two ways. While OTPs or narcotic treatment programs are licensed as outpatient providers, which would mean that therapy services and hours according to ASAM would be delivered according to outpatient or even intensive outpatient treatment hours, the 715 regulations indicate a minimum standard that is far less, which are the timeframes noted on the slide: 2.5 hours a month, 1 hour a month, or 1 hour every 2 months, depending how long an individual is active in the program. Even though Pennsylvania regulation indicates in any of these instances that additional therapy should be provided as needed, often the minimum requirement has been the standard of care. The first ASAM alignment issue that DDAP is encouraging OTPs to provide is an improved delivery of therapeutic hours and services based upon the ASAM criteria through individualized treatment planning based on 6-dimensional assessment. Secondly, if an NTP cannot provide the intensity of therapeutic services that an individual needs, a referral to another provider for clinical services should occur while maintaining medication services, until which time the individual can return back as appropriate. So, moving on to the Pennsylvania Specific Expectations Addendum information, let's discuss staffing credentials first. DDAP embraces the rich heritage of lived experience that has held a long presence in our treatment field, and acknowledges the benefit of licensed clinicians as described in the ASAM criteria. By striking a balance of education and training that can be acquired through the certification process, we will continue to have a gateway for those in recovery or those who do not have graduate degrees to gain experience through a mentoring process, while at the same time more fully embrace the credentialing process that already exists in the state through the Pennsylvania Certification Board. Staff hired prior to July 1st, 2021 will not have to meet this requirement as long as they remain with the same employer. However, if an employee hired prior to July 1st, 2021 seeks employment with the new provider, they will need to become certified under the protocol for new hires outlined in the addendum document. New hires after July 1st, 2021 must meet the minimum education and training requirements outlined in the regulation at the time of hire, and then be expected to be working toward meeting the licensure or certification requirements after hire. They will have 1 year beyond meeting PCB requirements to obtain certification. Therefore, depending on the type of certification, level of education, and experience, this expectation should be met between 1 and 4 years after hire. Because appropriate use of ASAM criteria is reliant upon a working knowledge of the stages of change and motivational interviewing, all assessors and clinicians should have an immediate foundational awareness of this information. This can be obtained through any number of self-selected online trainings, independent reading, facility, in-house guidance and instruction, etc. A record of how this foundational awareness was obtained should be maintained in each employee's training file. However, if formal DDAP-approved MI training has not been completed prior to July 1st, 2021, staff will need to obtain this training over an incremental time period. Clinical supervisors are expected to have DDAP-approved MI training by July 1st, 2023, and all other clinical staff are to have the training by July 1st, 2026. After 2026, All new clinical staff will be expected to have the MI training within 18 months of hire if DDAP-approved training was not previously obtained. Regarding independent assessment, in many, if not most instances, SCAs or their contracted providers are conducting level of care assessments and then referring individuals to providers for treatment services, rather than a treatment provider conducting its own level of care assessment. This independent process is necessary to avoid bias, as even implicit bias can likely occur. In those instances where a treatment provider must conduct a level of care assessment, there should be a process to assure evidence of neutrality when provider-conducted level of care assessment occurs. While additional information will be put out by DDAP's County Program Oversight section regarding this, evidence of neutrality will include client choice, data that indicates referrals to providers other than the one conducting the assessments, etc. DDAP and SCAs will begin to include this in the monitoring tool beginning February 2021. When an individual is being referred to any level of care, with consent, the level of care assessment should be forwarded to the receiving treatment facility to review with the individual and incorporated into their record as part of the intake process, rather than the treatment provider conducting a separate level of care assessment with the individual upon admission. Best practice warrants that the information in the level of care assessment is confirmed and validated. In fact, in item number 6 of the assessment treatment plan review self-assessment checklist, it reads, quote, "A provider has a written procedure that a clinician review all admission decisions to confirm clinical necessity of services, and that the review is within the clinician's scope of practice," end quote. Review does not mean redo. Instead, the level of care assessment that has been forwarded by the referring agency should be reviewed with the individual, clarified and even expounded upon if necessary, but not repeated in totality by the receiving treatment provider, as such is unwarranted and unfair to the individual. While accurate information is important for clinical assessment, establishing the biopsychosocial, and creating the treatment plan, a total reassessment is unwarranted. In fact, Licensing Alert number 1-2007 speaks to the issue of the use of an assessment being forwarded to a treating provider, and all providers should engage in this person-centered practice of using the level of care assessment provided by the referring entity, rather than redoing the assessment upon admission to treatment as best practice. In closing, DDAP would like to remind everyone that alignment with the service descriptions continues to be a process in which DDAP will offer as much support as possible. Providers should begin the alignment process now by reviewing the service description document, the self-assessment checklist, and the Pennsylvania expectations document. Identify those areas that require work and create an organizational strategy and plan, including your own timeframes, for completing each of the items on your to-do list as indicated by the self-assessment checklist. Use the overall timeline that DDAP will be making available to gauge how your plan fits into the overall expected timeframes for alignment. you will see when the timeline is posted to our website that most items will be required to be aligned by July 1st, 2021. Therefore, do not wait until the last minute to engage in the process so that you have time to internally accomplish the necessary tasks, ask questions of DDAP, and, if necessary, make adjustments along the way. For those of you who did not already use the chat box to sign in as an attendee of this presentation, please do so by indicating your name, your agency, and your agency's location. For those of you participating by phone, please email your attendance indicating your name, agency, and location to ra-daasam@pa.gov. Otherwise, please note that you can send any questions you have about today's presentation to the email noted on the slide. For those of you on the phone, the email address is, again, ra-daasam@pa.gov. Once again, that's ra-daasam@pa.gov. DDAP will be hosting 2 question and answer webinars with the same content on different dates, August 28th and August 31st. You will join the meetings using the Skype link designated for the specific date you want to attend. The links are found on the ASAM rollout schedule noted on DDAP's website. We will also do a written FAQ, which will be posted on the website around this same time or shortly after. While questions will be received anytime, in order for them to be included in the webinars or the FAQ, please submit questions no later than August 20th, and please include outpatient presentation on the subject line of your email. A recording of today's presentation will be available along with the PowerPoint slides by the end of next week or soon thereafter. Please watch DDAP's listserv for an announcement regarding availability. This concludes our presentation today. Thank you for joining us.